This is a show about the diversity of academic and experiential backgrounds of people working in patient safety. My name is Ivan. I am a lab rat turned infection preventionist. While struggling to find work, I reached out to a friend for support. Our chat turned into a LinkedIn post that showed me that many people in our field were in the same situation. The purpose of the Safety Spectrum podcast is to celebrate credential, educational, and experiential diversity, to share the values and success stories of non-traditional staff in quality patient safety and infection prevention, to advocate for competency-based versus credential-limited hiring, and to increase awareness of the importance of the infection preventionist and other roles in the healthcare safety sector. In this, our premiere episode, I talked to MJ Joseph. She is an infection preventionist, healthcare epidemiologist with experience spanning clinical care, public health strategy, infection prevention, and applied research, and an avid gardener. Welcome to the Safety Spectrum.
MJ, we met very briefly at APIC. And I think had a very wonderful conversation. Brief, but wonderful. Yes, very much to the point. And our topic of conversation was the need and just the situation in the industry of infection prevention and control, where for most job postings, nurses are preferred, sometimes even required, and how that affects us as non-nurse infection preventionists. Your background being medicine and public health, my background being lab. But I never really told you the story of how this podcast came around. I have been in infection prevention and control for 17 years. Before that, I worked in a hospital lab, and so I'm a lab rat turned infection preventionist. But sometime in 2023, I resigned from my position. Just pandemic was over, and I needed a break. I needed a break. My family said I needed a break, and I decided to take a break. I got on my motorcycle and rode to California, and it was a wonderful, wonderful thing to do. But when I came back home, I started looking for work, and I was astounded by how many positions required nursing credentials or preferred nursing credentials. And I'm not saying that experience is everything, but there was one job in particular that just where they were more interested in a nurse with 2 years of infection prevention experience, no certification, over a lab rat, myself, with at that time 14 years of experience, CIC, and a fellow of APIC. And that for me was just kind of this almost an explosion moment, if you will. It's just a what's going on kind of moment. And a good friend of mine, Jill Holdsworth, made a post about it on LinkedIn, and a bunch of people started talking, and then eventually a few years later, here we are. So welcome to the show.
Thank you so much. It's an honor to be here with you, Ivan.
Wonderful. So tell us a little bit about your career background.
So at a young child, I always knew that I wanted to be a doctor. And it was so funny because I always wanted to be a pediatrician. And at some point, I got going, did undergrad, went to medical school, and I can remember when I was doing my OBGYN rotation, my professor looked at me and she said, "What kind of physician do you want to be?" And I said, "A pediatrician." And she said, "No." She's like, "You're an OBGYN." And I thought to myself, I do not want to be looking at vaginas all day long. And so I was like, but eventually it was calling me, as time went on. And so, everything was great up until that point. Last year of medical school, right before graduation, I started experiencing these signs and symptoms that really required me to get a multidisciplinary team of medical providers. And and during that time, I still was able to graduate, still was able to push forward. But at one point, my team sat me down and they spoke to me and they told me, hey, this level of stress that you're dealing with is not helping us to be able to pinpoint what's going on with you nor your treatment. So we really need you to take a step back. So of course, you tell someone who finally feels like you made it to where, you're to your dream, that I feel like my whole world came crumbling down. And of course, most people probably realize I'm a type A personality, overachiever. So you say that to me and it's like everything just stopped. But eventually I did have to stop and had to move back in with my mother at the time. And in order to consult with all these providers and all these tests and everything that was going on. And I remember one day I was so angry at medicine. I became very angry at medicine because here I am, a physician, and I'm working with a team of 10 physicians who are some of the best physicians, and we can't seem to pinpoint what is happening. And so for the first time in my life, I was in that patient position. And I was frustrated because I felt like this should be very easy for us to figure out what's happening here. And it wasn't easy. So at that time too, I was like, well, since I can't technically work full time the way I would like, and I started at that time examining another route, which was not treating illnesses, but preventing illnesses. And I decided, and I told my mom one day, and said, I'm going back to school. And she's like, again, for what? And I said, I'm going back to school. I want to get a master's in public health with a focus in prevention. Because for the first time in my life, I was realizing that true treatment is it's not simply treating an illness, but the best treatment is preventing the person from becoming sick in the first place. Because no matter how sick you are, there are some treatments I can provide, but it won't provide you your full, your full capabilities back, your living possibilities. So I went back to school, got my master's in public health. While in public health, while doing my master's degree, I saw something about infection control. They had where you can get a certification in infection control. And I saw something on emergency preparedness. And those two things it just resonated with me. So I got a certificate and my master's degree in infection control and emergency preparedness because I was always into global medical work to begin with. So it was something that was dear to my heart. And that's how we got started. And I started with the health department as an epidemiologist, a senior epidemiologist working, and then had the epi team, even though I was under public health and emergency preparedness, coming to me with medical questions. And one day, one of the lead nurses said to me, he's like, you would make a great infection preventionist. And I was like, what's that?
Let me get, yes, what's that? That's a standard response.
And so, and he was sharing it with me because he was trying to become an infection preventionist. But he was
Okay.
So he was like, but he hadn't been able to pass the exam. And so, he was like, I'm still studying for it. But he's like, but you would have no problems passing the exam and doing everything. He's like, because you know all of our micros, you know the medications, you know the treatment. He's like, we come to you when we can't reach the doctors at the hospital. So, and that's how, and then when COVID hit, I was receiving calls from different recruiters regarding, epidemiology and looking for someone with a medical background. And that's how we got started and with the health department. And I, kept that little note in the back of my head, like about the infection prevention. And I was like, and one day I was like, just when COVID started to cease a little bit, I was like, I want to combine those two worlds of epi and infection prevention and medicine and everything else that I have under my belt. And that's what I did.
That's wonderful, and it makes you just a very, very unique infection preventionist, which is absolutely wonderful. Yes, that is brilliant. So you talked a little bit about you trying to create this melding of medical practice and public health education. How has that influenced your approach to designing infection prevention and control programs in the hospitals and facilities where you have worked?
Oh my gosh. I think honestly that has been my secret sauce, because a lot of times when I come, and this has happened to me in the last two facilities that I've worked at, that I will come in, either it's a facility that's really struggling, that has a couple of hits on them, or they're right about to have their survey. And of course, they don't tell you that during the interview. So now one of the questions I do ask is, when is your next survey?
What is the next? Yes, absolutely.
So, it has been an amazing journey, because it does give me a lot of avenues, and to be able to intertwine those worlds has made me the infection preventionist that I am. And I've even had my CEOs say to me, I've never worked with an infection preventionist like you. And I share with him, I said, I think it's because I've been blessed to bring other specialties and careers to the field, and I advance it and I make it work. Now, have there been times that I propose something and they're like, wait a minute, has this ever been done before? And, and I have to be honest, and I'll tell them, no, it hasn't. However, based off of some of the research that I have done and things that I do know, combining this should give us, and I'll give them a probability, even though they may not know what it means, but it's promising. And then we'll try it and they'll be like, oh my gosh, this is working. And one of the things that I was fortunate is to work with a healthcare system that was a system where we had multiple hospitals. So when we try certain things and we see that, the rates have decreased, the infection rates have decreased, or we're getting the outcomes that we're looking for, then we release it to all the hospitals. And we just go with it. And that's how we keep building on our infection control plan. And we keep submitting different new practices, evidence-based practices. And, and hopefully sooner or later, we'll have some things that publish.
Wonderful. And at the end of the day, that's how we make patients safer, right?
Absolutely.
That is exactly what we're trying to do. How important are certifications like the CIC for non-nurses? I think for nurses too, but how important are certifications like the CIC for infection preventionists?
That is a wonderful question, because to me, I don't even think that should be questionable, if that makes sense. Because CIC is extremely important. Just like, for medical school, you have to have certain, exams that says that you have met the competency. For residency, for nursing, you take the NCLEX. All these certifications are in place for a purpose, because what we're doing is, or essentially what it says is that this person is competent in their field of practice. And I agree with you. It should be also for nurses as well, because honestly, I love working with my nurses, but I can honestly share that a lot of the trainings and retrainings and coaching I do with the nurses, So you can be a nurse and you have been working bedside for a long time, but the world of infection control, let's be honest, it's completely different, and it's completely different. It is not the same as bedside, because even though we have certain protocols that are put in place by the quality team, you still need someone who's an expert in infection control to observe and make sure that these things are being followed appropriately. And when they're not, to identify where is this gap and how can we fix it.
Yes. One of my conversations has been around the reality that nurses bring all of that clinical expertise to an infection prevention team. public health folks bring a lot of the analytics just out of the gate, and that certification, the CIC, is and should be the equalizer of all of these different medical backgrounds. So in essence, it does not matter where an infection preventionist has come from. After they have passed the CIC, they pass the muster.
That's right.
Pretty much.
Right. It
Wonderful.
shouldn't be negotiable at all. It just says where, because you can be a med-surg nurse working bedside for 20 years, but I don't expect you to be an expert in the OR or endoscopy or SPD, because if that's never been your area of experience, there's a lot of things like sterility that you're not going to understand. And that's understandable. However, if the person has received the core knowledge from their and passed their CIC, then I would expect you to be competent in those areas.
Excellent. How have you, as an infection prevention leader, affected or tried to affect hiring practices in the facilities where you have worked?
Well, I can tell you, again, I have a very strong spirit of discernment. So, now these days, everyone's into AI. And so resumes don't impress me. Initials behind names, I'm not too impressed with that. But when we get to have a conversation and I can ask you questions that are applicable to that role that you're going to be in, or I can give you a scenario and ask you to walk me through how you would address this, then that gives me a better understanding. Does this person have the knowledge in order to fill this role? Not to say you're a bad person, but then it also gives me an idea too of, what? You may have some knowledge, but not have all the knowledge that's required. And that gives me an idea of where we can start with training you.
Okay. Wonderful. That's very good information to share. So you do not focus on the letters.
No.
You focus on the conversation.
I've seen lots of letters, and then we're like, I don't even know where these letters came from. I don't understand.
In some of the places you've practiced, you've talked a little bit about bringing in these novel concepts where you are taking research and essentially formulating new practice standards. What practical steps make the biggest difference in that work?
I really honestly have to say, I think it's the power of influence, the ability to influence others to want to reach higher. And I am blessed with that ability because I'm very passionate about what I do, especially when it comes to patient health, patient safety, because, and I think when I interact with the nurses, because let's be honest, normally infection prevention, most nurses are not excited to see infection prevention when they come on the floor.
Nope. The hand washing police are here. Everybody run and hide.
Everyone's in hide or checking to make sure that they're doing hand hygiene.
Exactly.
However, in my facilities, honestly, I think my personality plays a big role in that too, because I work with the physicians very well, and I think it's because of my knowledge in medicine. I work with my nurses. I work with every single person who makes that team in the hospital, from EVS down to anyone. And so doing that, it shows my team that we are a team. Because one of the things that I emphasize is that I am here to help you to be a better nurse, to help you to be a better provider, to help you to be a better employee. So how can I help? How can I support you? I'm here to work together so that we can make sure that patient safety is number one. So that is the collaboration and teamwork, the rapport. I used to have nurses that say, I love it when you come on the floor. And I'd be like, really? And they're like, yeah, whenever you come on the floor, you remind us to check those central line, the central line dates. You remind us to look at the dressings. And I was like, oh, okay. So, and they know I will sometimes just go on the unit and be like, hey, Ivan, how's it going? Do you need anything from me? Is there anything I can help you with? And it lets them know who you are too. Because I think it's a sad scenario when when nurses or providers or staff do not know what their infection preventionist looks like. They should know.
Absolutely. Yes, yes, and just to tack on with collaboration, I like what you say there, where you are going to these departments just to check on
Oh, yeah.
people, not because you have an
Right.
agenda, but because you genuinely care about them. This is your team. One of the things that I enjoyed the most about working in infection prevention, but was incidentally the most difficult part, especially during the pandemic, was our role is to protect the patient, yes, but infection prevention is also there to protect the staff.
Absolutely.
We have to protect our staff, like we have to protect our team, and it was wonderful because I got to do that. I got to do things that kept doctors and nurses and radiologists and all of these people safe. But yet at the same time, it was difficult because when the holes in the cheese lined up and someone on our healthcare team got sick, that was a difficult thing. That was a difficult thing for me to manage, and so I love that you are passionate about keeping the staff safe too, and that's a message that we as infection preventionists need to share when we go out rounding and people are running and hiding. Like, hey, I'm here to keep you guys safe too. So
And to be honest
that's
with
great.
you, that is something that I live by. And that's one of the commitments to my team. And I used to tell them, I said, I'm not just here for the patient, but I'm here for the hospital. I used to say, I sometimes like, this is my hospital because I'm responsible for the infection control. You understand? And I'm responsible for the safety of every single person that walks in through that door and making sure that they're coming into somewhere that is safe. And I used to tell the staff, I said, one of my responsibilities to you is to make sure that you are not taking anything home to your loved ones. But I can't do that
Yes.
without your collaboration.
Mm-hmm.
So, and that's one of the reasons why too. I mean, they will call and I encourage them, if it's something that you can't find in the policy, please reach out, call me, leave a message, do whatever you need to do because safety is number one.
Mm-hmm. That's great. Collaboration is crucial. All right, so we're going to talk a little bit about challenges. In your recent one of your LinkedIn posts, you pointed out how foundational things like hospital cleanliness and sharp safety are often overlooked. Why do you think we get these basics? That these basics sometimes are ignored in healthcare systems?
Well, there's a couple of things that I can probably point out, not to say necessarily that that's the main reasons, but one of the major observations that I made was staffing, especially due to budget cuts. When we are understaffed, not realizing providers have a tendency to take shortcuts. And, and that can be understood because obviously if you're being slammed, you're really not paying as close of attention as you would if you had the appropriate staffing to patient ratio, right? But in another thing that I could say that I have been very dear to my heart is staffing when it comes to environmental service. Environmental service, I mean, we can't have a clean hospital or environment without EVS. However, when you think about, the pay rate, for an EVS worker, sometimes it's not so appealing to bring in the best EVS staff. So you have staffing as far, from budget cuts. You also, another observation that I made is especially in staff who've been in the field for a long time. I've had to pull a few nurses aside and have a conversation because, things that I would observe that, dealing with sharps particularly that were not safe practice. And, and some were like, well, honey, I've been doing this since before you were even born. And I said, I understand. I said,
Yes.
I understand, and you're probably right. I wasn't born yet. However, this is how we do this. You know,
There's a better way to
yeah.
do this.
And and like, and I help them to understand too, is all it takes is one slip up, you know, and that can lead to a lifetime of regret. So we definitely don't want to, we definitely want to address these different little, gaps that we see, but obviously you won't be able to really observe those gaps if you're not on the floor. So I'm not an infection preventionist that just sits in the office. I can definitely tell you that.
But the office is so comfortable. No, that is yes, you are exactly right. I met someone. I'm trying to remember what this person did, but it's it may have been a lawyer or something in a hospital, and they said something along the lines of, if the CEO does not show up, the hospital still runs. If environmental services does not show up, this whole place is going to grind to a halt.
That's right.
And for me, that just showed how critical, it was a nice way of saying how critical environmental services is. But like you were saying, the pay is not commensurate to the value that they bring to the healthcare team. The same can be said for sterile processing departments and OR techs and just so many other positions in healthcare whose role is very valuable, but their remuneration for their work does not reflect that. So that's
I'm hoping that changes one day. I'm really hoping that changes because, especially environmental service, you think about they're one of the front lines when it comes to infection, right? And we definitely saw how valuable they were to the team when it came to COVID. Because, you don't have nowhere to put a patient if the room is not clean,
exactly.
And so, I'm really hoping and praying that that changes. Maybe someone will watch this podcast and decide to do something about that.
Right? Yes, absolutely. So just off the cuff, where do you think conversations like this one in particular with regards to EVS and remuneration, where do conversations like that gain the most traction?
Well, I would have to say, especially, for example, in the role of infection prevention. So one of the things I used to share with my different departments is I used to tell them, use me as your resource. Use me as your resource. Because, and I'll give you a perfect example. When I first started at a facility, the team was sharing with me that almost every other day their motivators were going down. And this would obviously cause delay in patient care, etc. And so, and they said, yeah, it's been doing that for over a year now. And I was like, really? I said, well, what are you doing about that? And they're like, well, they told us there's nothing they could do. And I said, I'm sure there's something we can do. And I said, do me a favor. Every time it breaks down, I want you to put in a report and make sure that I'm sent that report as well. So, and they started doing that. And we started seeing literally the cost that it was costing us every single time that this machine went down. And how they had to go back and reprocess because things got stopped midway and the cost involved in that with material. So when we were able to do that, then the CEO was like, well, when you look at it makes sense. Let's get a new one. And I was sharing with them and even the other departments, make sure that you are accountable for how you're utilizing your resources. And make sure, like you said, you're speaking to the right people. Sometimes we don't know who the right person is to speak to. However, we can make sure that we voice our concerns, especially when you're given opportunities to say what's going well, what's not going well. Sometimes people are afraid to speak on that. But obviously, I'm one of those that be like, ooh. So,
I have a whole list.
But one of the great things too that I always encourage a team is don't just come with what's not going well, but also show up with some solution. What have we tried to do? What are some options that we have to work with, and and how can we fix them?
Okay, so in addition to collaborating with all of these teams, you establish essentially two-way communication with them, where you are bringing in, this is infection prevention and control. This is how I want to help you keep our patients safer, keep yourself safer. But now you are also a conduit and a resource for them to escalate their concerns up to senior leadership and the people who have, whose ear you have.
And I'll add to that too, because, for example, our senior leaders, the C-suite, their concerns normally is budget and numbers, right?
Yes.
So,
Yes.
And this is one of the areas that I feel that infection control is very vital as far as like making sure that we do have a nice scope of what's happening in the hospital from infection control perspective and the tools that we need and resources. Because there have been times that, for example, in that particular situation, I remember one day I stopped by the CEO's office and I knocked and I said, hi. And he's like, oh, hey, MJ, what can I do for you? I'm like, I'm glad you asked. I said, do you have a second that we can take a walk? And he's like, sure. I took him in there to show him because, obviously he's not the expert in this department, right? So just throwing these words at him and throwing these things, it may not click the way we would like it to click, right? Because that's not his area of specialty. But when I can show it to you and I can explain to you, this is what's happening. And I can show you the numbers of how it's affecting our facility, how it's affecting the performance of SPD, how it's affecting endoscopy. And, and this is what it's costing us. It makes a lot more sense for them at that time. So then it's easier for them to come to the table and bring everyone to the table. I love bringing all this, the appropriate stakeholders to the table because, hey, if I can create that space to have you speak for yourself, then I'm going to have you at that table and I'll be there to support. And that's how, I was able to accomplish and get certain things addressed and in a meaningful time and making sure that, the two-way communication and everyone's on the same page.
That is wonderful. That is wonderful. How do you mentor new infection preventionists to build both technical skills and the confidence to advocate for patient safety?
So there was a period, I want to say it was November of last year, where 6 new IPs, all RNs, were flown in from one of our sister hospitals in a different state to train for a whole week with me. And, 1 week of training, if you're new to infection control, is nothing.
That's not enough. No.
But so one of the things that I try to do is definitely providing the bigger picture to a Novak IP, and we're helping them to gain confidence and what they do know and to build on that. So one of the ways that I do that is helping them to understand too that your attitude towards infection control makes a huge difference. It makes a huge difference. So you have to have the right attitude because that it spills over when you're working as a team, when you're working with the nursing and the clinicians. It spills over. So having the right attitude and not being afraid. And, so a lot of it is mostly building character and, kind of like building character and giving that confidence like, hey, we're not expecting you to know everything. Do not be afraid if you don't know everything. This is how you learn. And don't be afraid to learn, right? So the great thing with working in a hospital system was that you did have other resources, other IPs that you can reach out to and ask a question. But of course, you still have to have that confidence to make that call or to send that email and ask for help. So I used to always encourage them, especially when it came to me, I used to tell them, hey, do not be afraid to ask me for help. So, there are things that I had that I would send to them, like little templates that I used. I would provide them those little templates. When they would come to my hospital and spend a whole week with me, I'd take them everywhere to the dirtiest places. That's where I start. That's normally the challenges, because,
Yes.
I've had facilities where I show up in endoscopy and they're shocked to see me. And they're like, IP never comes up here. And I was like, what do you mean IP never comes up here? And then they're like, they don't come up here. And a lot of times it's because they don't feel confident in that in that department, so they don't want to, seem like they're not knowledgeable, so they don't show up. But no, that's not the approach. The approach is you should show up even more so that you can learn, right?
You show up to
You show
learn.
up to learn.
Exactly. You show up
And
to
so I had to
learn.
tell them, I said, anywhere that's dirty, I am going to be all in your Kool-Aid. If there's any risk of infection, I will be there. So, I take them to some of the areas that I know most IPs aren't comfortable, and I allow them to actually do an audit with me. I allow them to do a walkthrough with me. I allow them to ask me questions. But one of the other things that I share with them, especially when we're doing audits, I try to train them on how to think like an auditor. When CMS shows up at your hospital, when Joint Commission, when DMV, when whoever shows up, if you've been thinking the way they've been thinking, more than likely you found a majority of what they would find.
Okay. So, firstly, show up to learn. And secondly, go through the department as an auditor would. That way, you're preparing your team essentially for the real
That's right.
world.
And you're always ready. Because if you're always ready, you don't have to get ready, right? And the thing is, and it gives you an opportunity to be on the units. It gives you an opportunity to learn the staffs by name. And you may not learn all of them depending on the size of your hospital, but they should definitely know you, right? So being present, be present.
Mm-hmm.
And obviously, even after you've obtained your CIC, there's still so much more to learn in infection control. So never stop learning. Never stop learning. Never stop reading. Definitely, keep building on the knowledge that you have, because there's always something new to learn, or you can create something new as a new initiative, in infection control.
Yeah. When I started my role at my last hospital during my first month, whenever I walked around with people, I would always ask, where does that door go? Can we go in there? What's behind that door? And that is how you find out where things and places are, right?
Yeah.
That is how you find out where everything's hidden.
And when the IP's on the floor, they're always throwing something behind a closed door.
Oh, that is so true. So, if you had an audience with healthcare executives, what is, unfortunately, we're only going to allow you just one thing to talk about. What is that one thing, that one infection prevention investment that you think they need to focus more on?
I would probably have to say, and I know training is already, a part of what we think we do, but definitely training with devices.
Okay.
Yeah, devices have been, earlier you talked about, the decreases that I was able to obtain in my hospital. And when I came into that hospital, they were a Leapfrog C. And I'm happy to say that they've been an A now 4 consecutive terms in a row. But part of that was when I came in and they told me they were a C, I wanted to go through and look at their whole analysis. And I realized that where the fallout was an infection rate with devices, right? And so education, cannot just be it can't just be something, an online course that people say, because let's face it, majority of people that've been working in healthcare, they'll put on the training and walk away and not really receive training, right? So now
we'll click through the slides, or we will watch the training while we're doing something else.
So, so one of the things, and that was part of, being on the unit, and one of the reasons why whenever I do roll out something new, that I will show up early in the morning to catch the night shift, and then to catch the morning shift, is provide the training, going in the rooms with them, making sure that they are confident, because obviously you want your staff to be confident in what they do. And also too, another approach that I took was using the vendors to come in and do annual assessments, because I was telling them, hey, this is part of the contract, guys. In case y'all didn't know, you just got to ask them to come do it. And so our facilities are now very comfortable with different vendors coming in annually to assess our practices. And because if we are well trained and we are doing what we're supposed to be doing as healthcare providers, then we've created a safe environment for patients.
So education, but not just going through slides, but making sure that we're doing competency-based training and people are, showing that they actually get what we're teaching.
True training. Back in the days kind of training.
Back in the day kind of training. The training we did before you were born. Right?
Exactly.
So you bring a rich clinical and research background to infection prevention, not strictly nursing, which is wonderful. How has that shaped, or how does that continue to shape your path in infection prevention?
Oh, I love it, to be honest with you, even though, during my transition, it was devastating, but it has come together like a mosaic glass, to create a wonderful image and glow, because having a background in medicine, epidemiology, and public health really has given me a unique lens to look at infection prevention. And, and just, having like you said, from the public health side, you bring the data analysis and the population and health and surveillance and the outbreak investigation and, the evidence-based research. But, it gives me a leverage that is beyond clinical support, right? Because when there are when there are outbreaks, for example, in my area, and I get that call, one of the first things I ask for, what are the signs and symptoms? What are the signs and symptoms? Because it already gives me an idea of what I'm going to be working with. And I can better recommend for my staff what practices, what do we need to put in place? Because I think of, for example, for myself and having an emergency preparedness background, when I get a call, like I'll give you an example. One time we got a call from Houston Fire Department, and it was like, they have a group of patients that's being flown in from a ship. They're all presenting with the same symptoms, but no one knows yet what it is. So there's a few things that starts automatically, shooting off in my head, that, maybe most IPs probably wouldn't be able to, because like you said, if they don't have the clinical background, but also too, just those experiences, I already know, what I'm thinking about. And then and having the IP end of it, like, okay, well, what kind of isolation do I need to have? What kind of, protocol do I need to put in place? Who needs to be in the front line? What needs to be said? Do we need a barrier, set up? Do we need to build, is it airborne? Is it droplet? You start thinking about all that stuff, and I bring it all together because my first inclination is, how can I mitigate what's happening here to the best of the ability to protect the public health as well as my hospital and my staff, while still providing the patient with the optimal care. So for me, it just, and I'm very proactive. So I'm always thinking about the most cost effective way of doing things, and definitely, being a type A personality, what's also the best way for us to do it.
Okay. All right. I think so far I'm coming up with a summary of your whole career, and so far I am landing on an ounce of prevention is better than a pound of cure, because you've talked a lot about how prevention is better medicine. You've talked a lot about being proactive. You've talked a lot about. I think you bring just this high level of foresight which is wonderful to hear. What advice would you give other non-RNs who are trying to break into infection prevention but worry about lacking clinical experience?
Well, I would definitely recommend that individual definitely gets your CIC. Definitely get your CIC certification, and don't stop there, because like I said, there's so much more, than just CIC that can help develop. Also too, and I tried to explain to every IP, find what works for you. Don't try to mimic another IP. It's not going to work. You're going to get frustrated. But find what works for you. What is your thing? How can you convey what you have and what you've learned in IP, and maximize on that? Because depending on what kind of setting you are working in, depending, if you're acute, LTAC, or, health department, or, public health, it's a different arena for all the different areas. However, we can still contribute, because in reality, it's public health. When I'm in the hospital, even though it's acute, I still can play a role in chronic diseases and public health and population health, community health, excuse me. So, what we do in whatever role that we are in is very important to the overall health of this world, right? So my recommendation was definitely find someone who you trust, that you can obviously have a source, that you can reach out to. Make sure you create a network with other IPs who have experience, whether you use LinkedIn to find a few, or whether you work in a hospital system and you have other IPs at other facilities. Create your own network and build on that. Okay. Definitely become an APIC member, because that is a whole community within itself. APIC has the focus groups. They have a focus groups for, acute facilities, LTAC. So they have all whatever focus group you can think of, and definitely show up, be present, and be willing to learn. And it's okay if you don't know everything. Walk into endo and speak to your lead endo tech. Hey, I would like to learn more about what you do. Can I observe you, and can you walk me through this? And one of the ways too that you can do that I've trained other IPs on is I'll tell them, get your audit sheet. Get your audit sheet. If you have a great audit sheet that tells you kind of like what it kind of guides you on what you should be looking for. And as you're making this observation, and this person is telling you, this is what I do, this is step 1, this is step 2, you are learning it. And after you've seen it a couple of times, you have a pretty good idea of what should be going on. So don't be afraid to ask questions.
Absolutely. I had a wonderful conversation with Chaz Rohn, and he said something along the lines of, make sure to highlight what you bring to the table. You said something that I liked very much. We all bring something slightly different, and don't try to emulate someone else. And just to add that to what Chaz was saying, you bring your own skill to the table. You highlight that, and you say, this is who I am. And you build if you get the job, right, you build your program. You build your program after that, and you don't try to be someone else.
Own it.
Okay.
Own it.
Yeah. Own it. There we go. I like that. Yes. What transferable skills from your research and public health work have been game changers in your infection prevention career?
So I've done a lot of research in public health, community health, and I think that one of the biggest transferable skills definitely was the data analysis, and being able to analyze data and being able to translate it as well. Because sometimes people will read, the common person who may not be familiar with data analysis may read something, and I read it and I'm like, no, I get a totally complete different scenario in my head, because what people don't realize is research can be biased. And if you are
Yes.
not a researcher and if you don't understand data analysis, then sometimes you may think it's saying one thing, but it's really saying something else. So having that knowledge, that epidemiology knowledge and the public health knowledge has definitely, especially when it comes to researching for new techniques or new devices, and reading the researches, for example, even when you're at different vendors, or dealing with different vendors, and they're like, yeah, we have this research, and it shows that this, they want to switch or, switch to this because this is ours is better. And, one of the things I always tell them, I want to see the raw data. And like,
Okay.
do you have the raw data that I can look at? Do you have your, can I see your research? Can I see the limitations? Can I see the bias? Because that has to be released, right? But how many IPs are going to ask for that?
Okay. So when you're asking for this information, is this like white paper information, or you're asking for peer-reviewed
Well, it
studies?
depends on their study. Because so
Okay.
most of their, most vendors, um, some will have meta analysis that were done, which is where they take like different studies from different places and do an analysis of all those data. Some will have their studies based off of meta analysis. Some will have their studies from peer review, like you mentioned, and that's also another thing to consider, right? Because it's like, okay, now was this research? Is this, is this research built off another research? Is there more? Because obviously, if it's built off of something else, but where's the, where's the first device that we're looking at that you built from? You know, so and the reason why I, in my opinion, feel that's very important when when it comes to making decisions for infection prevention, especially with devices and practices and different, one brand versus another, is because to me it speaks on the cost and the effectiveness, right? Because don't forget, every vendor wants you to contract with them, right? But again, it's what's in the best interest of the patient. What's best for the
Patients,
patient?
yes.
What is also best for my facility? Because my facility may look different than your facility, right? So, and of course, everyone just wants the contract because they want to make the money.
Exactly. Unfortunately, healthcare is a business, and there are business concerns that we face every single day in the field. Um, so we'll get a little bit personal, and when you are done with a long day of infection prevention and control, changing minds and changing the world, how do you relax? How do you get back to being MJ?
That is
How does that type A kind of slow down and
that is a wonderful question that I'm very happy to share. So I will get home and literally sometimes still in my scrubs, head straight to my backyard because I love to garden. In my
okay.
backyard, I grow. I have purple okra, green okra. I grow zucchini, squash, spaghetti squash. I have 8 pineapples. I have a peach tree. I have a banana
Wow.
tree. I have 2 lemon trees. I have a dragon fruit tree. I grow spinach. Anything I love to eat, sweet potatoes, carrots. Anything I love to eat, I can be out there for hours. And if I'm feeling very stressed, I will literally take a break and go in my garden.
Oh wow, that is wonderful. Well, thank you very much for your time,
Pleasure.
MJ. Passionate infection preventionist, passionate
Oh,
gardener,
yeah.
traveler,
Oh, yeah.
a leader who reminds us that prevention is better than cure. Right? Collaboration is very important in the work that we do. We are not infection preventionists alone. We work with a whole team of other people in healthcare who care about the patients as much as we do. And so our role is to support them. Our role is to educate them, and our role is to learn from them. Thank you very much, MJ, for your time.
Thank you, Ivan. It was a pleasure being with you.